Good morning. I think we have everybody here, even if we're starting a minute or two early. My name is Emily Deedy, and I've met many of you. I'm a retired CEO who volunteers with the VNAA and get to hear all the exciting things that you're going through. Our session this morning is Leadership Development Redesign, and it's presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded, and I've asked if you're going to ask questions in the future that maybe we'll give you the microphone or something to ask the question, so we've got it on tape also. And the continuing nursing education activity has been for one contact hour by the Maryland Nurses Association, which is an accredited provider by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive your certificate of completion, you will need to stay for the whole program, and I'm sure you will, and complete the evaluation, which is on your app, and then you can pick your certificates of completion up right over here as you walk out the door. Our faculty has disclosed no financial conflict of interest, and I've given some of you the copies of that. If not, and you want one, they're on the desk, and I'll be happy to give it to you today. I'd like to next just introduce our presenters, and some of them you already know. Ann Painter has more than 25 years of experience in home health care industry and demonstrated exceptional skills as a transformational leader. She was previously a CEO of the VNA of Somerset Hills in New Jersey, where she had oversight of home health, hospice, adult day service, and wellness programs. Her current position is Senior Vice President at Christiana Care. Her career has included various diverse positions of increasing responsibility, including Director of Hudson County, New Jersey Medicare Services, and Manager of Clinical Leadership for Beata Nurses. Excuse me. She was a Manager of Staff Development, Assistant Director of Operations, Director of Clinical Operations for the Visiting Nurse Association of Central New Jersey. She has also served as a graduate instructor of health informatics at Monmouth University. In addition to a diploma in nursing from the Ann May School of Nursing, Painter has an MBS and an MS degree from Monmouth University. I thought all of us three-year diploma people were almost finished. And she's been an active leader in the industry and has served as chair of the Home Health and Hospice Association of New Jersey and on the board of the New Jersey Collaborating Center for Nursing. And she's been on various committees within the VNAA. And Steve Richard, who will also tell you a little more about himself, has grown up with the home health and hospice industry, having held managerial positions for over 35 years while he was senior in college. Even while he was a senior in college, you did that. That's great. Most recently, he spent 7 years as CEO of a community-based nonprofit VNA. 3 years ago, as a VNA integrated into the Geisinger health system, Steve became the AVP for home health and hospice, bringing multiple providers under one leadership team. So I think we're going to have a lot of interesting conversations with them. And Ann, I think you're up first. Thank you.
Well, good morning, everyone. It's really a pleasure to be with all of you and kind of share a little bit of my thoughts and Stephen's thoughts on, where are we going in healthcare as far as leadership, because things are changing very rapidly. So the first thing I'd like to do is, we never work in a vacuum. I think it's in here. Oh, where's my credits? They're gone. Well, anyway, first of all, I just want to recognize my team that I currently work with. They're here. No one can lead an organization without people who are willing to follow, and change is difficult, so I thank them for their willingness to come on the journey with me. Judy Adamczyk actually worked with me before this, so I'm glad that you could join as well. And maybe if any of you would like to speak to them afterwards and kind of hear some of their personal experiences, I'm sure they'd be willing to share. I also just wanted to let you know that I've worked with an executive coach for the past 3 years. And the reason that I bring that up is I honestly believe that that has brought a great deal of value to me as a leader. It helps me to reflect. She sees things from a different lens, and she helps me also to think about how other individuals might be impacted. We all have blind spots. Mine happens to be sometimes in the area of change and how that might impact people. So there is value in having a great coach. My co-presenter, Cindy Goodwin, could not join us here, and I just also wanted to recognize her as well. So these are the objectives of the program. We're trying to make sure that you leave here with an understanding of what are some of the drivers, that there's been transformation in leadership roles in healthcare, to describe some skills that the nonprofit leader will need to have to improve patient outcomes and to reduce turnover, and also to discuss and describe some actions or tools that you can use as a leader in this environment. Just a little bit about Christiana Care. We are located in Delaware, the first state. We are a little state. We are 3 counties, but Christiana Care is quite large. It serves about 53,000 admissions every year, has a very, very busy emergency department, nearly 200,000 visits a year, and delivers about 6,500 births. The VNA itself services the whole state of Delaware, and we also go into a little bit into Cecil County in Maryland. We do about 310,000 visits a year. We are a home health provider. We do not have a hospice. I just want to mention that. And we have over 600 employees. We have 2 branch offices, one in the northern part of our territory and one more in the central part of the state. So what are the drivers? Why are we changing? If you look back almost 10 years ago, leadership was more of a top-down approach. We gave the directions, we gave the marching orders, and we expected our teams to kind of implement it the way we presented it to them. That will no longer work in the new environment that we are currently in and where we are moving. So the Affordable Care Act, as you all know, has moved us more to a value focus. There will be a lot of innovation. There is not a clear path forward, and that is why we will need a new approach in our leadership to help design that piece. We all know there are unsustainable expenditures for healthcare. The United States spends one of the most dollars on healthcare, but yet does not have the best outcomes in healthcare. And increased portability of technology is really changing our world. If you really just even look back 10 years ago, I know someone mentioned that the iPhone has only been around for 10 years. I mean, think about where we've come and what that has done to our world and as a role as a leader. And also there is continuous change in healthcare. So as leaders, we have to make our teams feel comfortable in a world that is constantly evolving. And we are constantly asked, when will the change stop? It's not going to. So we need to be able to support our teams and facilitate that. So today's leader and the future leader needs to be incredibly resilient. Since the path is not clearly designed with the steps that we have to take, we will make mistakes along the way. And part of our role in leadership is to really make sure that our teams understand that. Teams that are not empowered to make decisions and to try new pilots or projects will cause great difficulties in us moving forward. We learn best from our mistakes, and as leaders, we have to support our staff that that is okay, and what can we learn from those mistakes. Gone are the days where a leader held power and really could just kind of tell people this is the direction we're going to move in. So influence is really important. We work across the healthcare continuum. We work with partners at skilled nursing facilities, partners at hospitals and care management, emergency departments, community providers. So it's not a place where we have a power role. Our role is really a convener, a facilitator, and to influence others with a vision. The other thing that today's leader needs to do is we can't just be in a silo in our own organization and focusing on only what's happening inside our four walls, or actually in our own community. It is much bigger than that. So the leader has to be out, be involved, like some of you are here today at VNAA, learning and networking. That will be an important area in the future. And then making sure that you bring the key stakeholders to the table. So when you're working on a new innovative idea that maybe you had seen here at VNAA, when you go back, who are those key stakeholders that you need to bring to that table and look at it? So I'll give you just a quick little example. We are looking at potentially partnering with Select Data. Select Data has been to our organization twice now, and they have met with some of our team. So we had dinner with them last night, and someone might have asked me, it was the senior, very executive level leadership at Select Data that we went to dinner with, and someone might say, well, why would you bring 6 people to dinner with you? Well, because those people are going to be the people that are going to come up with the ideas, the process, the implementation, and to really tell me, is this a good idea? Will this work at our organization? So we as leaders have to bring the right people to the table because we're not going to be doing the actions to move things forward most of the time. So what do successful organizations look like in this environment? As I mentioned before, they have to scan broadly across the area, both from a state and a national level. If you think about when Trump, the president, came into office, there was a lot of fear from people who are illegal immigrants. Are they going to be deported? They don't want to come in for their health care services. And what does that mean to the organization? Am I going to lose my health insurance? How will that impact the people who need our services? So as leaders, we need to understand what's going on outside, but be able to translate to our team, what we expect and how does that impact our mission. Talk about that. Sorry. Trying not to lose my place. So I just wanted to share a little bit about our story, and I want to give time for Stephen to talk, and then you can ask specific questions as well. So in late 2015, the prior Senior Vice President, Chief Operating Officer, some of you might have known her, Rhonda Coombs, was retiring after 30 years of service. So Christiana Care put up a posting for a position internally. And you would think in an organization of our size that there would be probably 50 or 100 candidates who might apply. That wasn't the case, and that was a big eye-opener for the health system and also for the VNA. Like, where did we go wrong, or where is there opportunity? Because we should be able to grow some of our own from within. So that was a big, eye-opener for the organization that there were some gaps. So when I came into the organization, I started to meet one-on-one with staff to really try and understand, how did we get to that? Like, why would that have happened? And some of it is around feedback. Staff felt like feedback is often given only when it's negative or there's opportunity for growth, but not frequently enough for when they're doing things very well. Probably quite common because most of our staff don't physically come into our offices on a regular basis any longer, so giving recognition becomes more challenging. The other challenge is that, I think I mentioned this a little bit before, that top-down approach before where decisions are really made and then directions are given is a typical scenario. And that is how the organization at Christiana VNA kind of functioned before. So, the leadership would kind of give the direction and then the managers would come back and say, oh, what's the next step? And that doesn't allow for innovation and new ideas to move forward. And then the other area that we felt there was some shortcomings is that we knew who the high potential folks were as far as people who could move up, but they didn't have development plans. They didn't have like check-ins with their manager or leader. And they also, many of them didn't really know that they were high potential and that we were grooming them. So, we thought there's an opportunity there as well. So we also don't lose those individuals. Shortly after I joined the organization, the health system as a whole noticed that this was a area for opportunity, and they developed a department they call it iLead, and it's solely focused on leadership development. So it's undergoing a pretty big transformation. There's a committee that I'm working on right now just focusing on succession planning for key positions in the organization. And key positions are not always like the VP. They could be a nurse manager or a position that we know is going to be very difficult to fill and is critical to the operation of the organization. Also during that time, I asked the director of iLead to actually meet with my leadership team to give me some insight into, what was different and what did I need to be aware of. So some of the things I already mentioned was that my leadership style is very kind of hands-off. I want my folks, here's kind of where I think we need to be going. And then I like to see them take the reins and kind of go along with it and then check in with me regularly. That was not the prior leader's style. So it was important for me to understand that. And I think that insight was really helpful in understanding how I might have to help my team. Oops, just want to go back. Oops, sorry. Oh, just one other thing. So when I received that information, I set up monthly meetings with my senior leadership to really, first of all, give them feedback on what my style was and what my expectations were, because it was totally different from what they were used to. And also to give an opportunity for them to check in with me monthly, so they would have designated time with me, like about an hour and a half, to really look at what are the projects that they were working on, what are the action steps that they've taken, what help do they need, is there resources that they need, and to really help them to make sure that we're moving forward and meeting our goals. The second steps that we did is we really felt that organizationally giving and receiving feedback was not one of our strengths. So we had a leadership development course for that, and we had the director of iLead come in and provide that education to our team. And also I have a couple of tools that I'll share with you, but giving and receiving feedback is like critical to the development of leaders. It's critical to your staff. We had staff that said to me, I don't know if I'm doing a good job or not. I'm not getting feedback. I'm only getting feedback when I do the OASIS wrong or the 485 isn't right. I'm not hearing about the great outcomes that I did in lowering rehospitalization, or how am I doing with patient satisfaction? How do I impact that? So I actually went to the Center for Creative Leadership about 2.5 years ago, and I have to say it was just a wonderful experience. It is a little costly, but I will give you a little hint. There is sometimes grants for nonprofit organizations that you can apply and actually have the tuition at a much reduced cost. So don't count it out when you see the price tag, because I do think it has high value. So one of the tools that they shared there is called SBI, and it's a tool for giving feedback. And the tool is, what was the situation? What was the background? And what was the impact? So when you give an individual feedback, you want to do it right in the moment or closely thereafter. So if Gail did a great presentation on the outcomes that we're having from CMS and explained how maybe the area for opportunity, what that is, and then I share what the impact was with the team, then that is more effective than just saying to Gail after the meeting, hey, Gail, that was a great presentation. Well, what was great? What did I do that was good? What should Gail repeat the next time she has that meeting with the group? So, we want to make sure that we're giving that feedback quickly after that. The majority of feedback that you give to your staff and to growing leaders needs to be positive. If you're using the 80% negative and the 20% positive, we won't grow our staff, we won't grow our future leaders. And the other thing, too, is really to explain the impact and not use the word you. We tend to sometimes do that when we're upset, and really describe how it impacted you as an individual. That's the tool. And here's some of the pitfalls that sometimes we fall into with giving feedback. We wait days, months, or sometimes we only do it at the annual evaluation. Probably not the best time to give feedback, especially if it's growth feedback. So the other thing too is if you're grooming someone and you're developing them as a leader, as soon as you see that new behavior that you're looking for, that is the fabulous time to engage them in feedback and say, Gail, that was really great how you followed up and included the entire team with that problem that we were having with staffing. The staff really felt empowered by that. But you want to do it quickly after so that Gail knows what she did well. Poor Gail, she's like, sorry she even came to my presentation today. But you want to do it right after so Gail knows, like, what was it that I did? And wow, I'm doing a great job. I'm going to do that again. So you help to hardwire the behavior in when you give frequent feedback, especially when it's positive. And again, I think I already talked a little bit about avoiding the great job, good work. Those are very vague and they don't reinforce what the behavior was and what the impact was. And you really should try not to give unsolicited advice. You should have done this, or you should have behaved in a different way. Those are usually not very effective. They tend to make the individual feel defensive and usually don't work well. And the last thing is you really should never deliver positive and negative feedback together, saying, well, you did a really great job with the presentation about the quality outcomes. But on the press gainy, I really couldn't follow what you were doing. So that's really not the best way to do that. Maybe 2 separate conversations would be better in that case for that individual. The other tool that I've used, and actually my executive coach helped me with this tool, is called the GROW model. If you just Google it, you'll find the tool, and my references are at the end of the slide, so you'll be able to find some of these tools as well very easily. So with the GROW model, the G is what is the goal? What are they trying to achieve? What is the reality? What is the current situation that they're in? What challenges are they facing? What are the options? What are the obstacles in trying to get where they need to be? And then trying to come up with options to move forward. And then really, what is the way forward, or what is the next steps? It's a really great model for developing new leaders and existing ones. Oops. With this model, what I have found to be very, very useful is say you're the leader and your employee comes down to you and says, of course, it's spring break and we're all really, really busy and you have staffing shortages. So, of course, your manager's going to come downstairs to you and say, we don't have enough staff, we have too many referrals, you got to stop the flow that's coming in. Does that sound familiar to anyone? Yeah. So, the manager comes downstairs in absolute panic. We can't possibly take one more referral. Okay, so your response is you don't want to say, okay, let me go upstairs and help you solve the problem. Well, it might be better if you ask a few open questions first. And one of them might be, well, what have you tried so far? How did it work? What else could you do? Who else could you call? Could another branch help us? Is there any nurses that we might call? So you're trying to help the individual to solve the problem rather than giving them the answer. Many of us as leaders in this room could probably go upstairs and fix the problem in 10 minutes. But if you do that, They will come down every single time when they have that problem, and you will have to go up and fix it. It's really important to be able to develop and have them have those skills. So I just wanted to share some results with you, and these are some of the just kind of what people said actually in the survey that we did. And one person, actually 2 people, shared that they're delegating more. I happen to know one of the people that actually wrote that in, and she actually had 2 high potential staff members and really didn't have an action plan in place before. So just to give you an example, there was a nurse who has a master's degree in nursing, really wanted to move up into management. So she set her up with a development plan for her to go for a leadership course at the organization. And she also led a team meeting, so that gave her some new skills. And also she was given a small project at the hospital as a liaison to work on medication reconciliation. And then the 4th step was the manager for referral services was going out on medical leave. So the director came to me and said, I don't know what we're going to do. How are we going to cover that department? And I said, who might we be able to ask to help us? And another good tip is wait 20 seconds. People always will respond. If you give them 20 seconds, they'll definitely come up with an answer. And she said to me, well, maybe Monica could help us out. Monica is the individual I was just talking about. So it was a great experience for Monica. Now, we didn't just throw her in there with no support. She had another manager to go to, but it was a great experience for her. For 2 weeks, she was managing that department and learning some of the challenges that go along with being a new manager. So again, giving people the opportunities that they need. Reflection, we all need time to think uninterrupted. And we tend to be so busy with meeting after meeting after meeting that we never have time to sit back and really think about, where are we at personally, or where are we at professionally, or what are some of the things and the biggest challenges we're facing as an organization. More involvement and responsibility was one of the things that felt there was more involvement of direct care staff, especially sitting on our committees, and just more opportunities to develop their skills. The last one is an interesting one. Not sure, but it's working. What do you think that tells me? We didn't give enough feedback. So the person knows that thinks they're doing a good job, but they're not sure why. So again, another opportunity to think about how can we hardwire that behavior in, what is that individual doing well, and how can they repeat that? And then our results is we actually had 3 internal high potential staff who we set up with the leadership development plan, and each of those 3 individuals has now been promoted into leadership positions within the VNA. And I do have to say that I believe that at least 2 of those individuals were actively looking for jobs earlier last year. And I do believe if we didn't set up the development plan and some of the actions that we took, I think we would have lost those individuals, and that would have been a terrible thing for the VNA. So thank you. I'm going to let Stephen take over now.
Thanks, Ann. So I'm Steve Richard. I'm with the Geisinger Health System. As mentioned in my introduction, I started when I was a senior in college in home health. I was 20 years old. Have grown up with the industry, which obviously has changed a lot. For 32 years, I was involved with a nonprofit, independent-owned visiting nurse association. And at that point, I had served the last 7 years as its chief executive officer, and I negotiated our joining the Geisinger Health System. And at that time, we did it for a number of reasons. One was the fact that the area was becoming very heavily managed care, and reimbursement and finances were getting extremely tough. We were having extreme difficulties recruiting staff. As many of you know, that's a constant issue. I will tell you, though, that we had hoped that becoming part of the bigger health system would help that situation. In reality, what I have found is that when you join a health system that has 200 nursing openings, it doesn't help your recruiting. So there's a lot of things that we expected to happen that did not happen. One of the things that did happen is that I became the vice president in charge of home health and hospice for Geisinger, and I was tasked with bringing what was 5 separate providers into one organization. So we have implemented a common EMR, we have implemented common leadership across those 5 entities, and hopefully within the next 2 months, those 5 entities will now all exist as one entity that is unified. We're a very large geographic area, not near as large volume-wise as Ann's organization, but if you drive edge to edge in the service territory that we serve, you can drive about 4 hours, almost 175 miles. Very large area, most of it very rural. So I want to share with you kind of my personal experience or case story of what my experience has been. So a little bit about Geisinger Health System. Known for things like innovation, use of the electronic health record. They've been an Epic customer forever and have really done a great job of utilizing Epic along with claims data from both Medicare and the health plan and everything, and therefore have really advanced a lot of use and predictive modeling within the system. Innovative care delivery models. Proven care is a model where for certain diagnosis and procedures, when you come to Geisinger, you are quoted a price, and if you have complications and stuff within the first 6 months or whatever the time frame is, it's all covered, okay? You don't get a separate fee every time you come back. The latest experience or new model is called Proven Experience, and some of you may have read about this in the Wall Street Journal and various places, where Geisinger now offers to any of its patients in any of their medical centers, if you are unhappy with the services that you provide, you can ask for a refund of any out-of-pocket costs, okay? And the patient sets that refund amount, okay? So if you have been on a floor that has been very noisy and you didn't sleep, and you think that you'd like $200 back because of that poor experience, you get $200 back, okay? Some of you are saying, how can you afford to do that? Well, what they have found is that it's very inexpensive feedback, okay? The feedback from patients has really helped to promote the patient experience because patients are very willing to share what the things are that have impacted them and they're unhappy about. So that experiment's been in place for about a year and has actually been put in standard place and is expected to continue. A huge mycogenomics project, about 160,000 people have had their total DNA sequencing done, and that's being used not only for research, but also for predictive purposes. I can tell you a story about a woman who, because of the genetics research and her profile, they were able to identify that she would have an 85 to 90% chance of getting ovarian cancer. The patient was made aware of that, went through a series of tests, no cancer was detected, but because of her specific situation of caring for grandchildren and wanting to be sure that she was going to be around for years to come, she chose to have her ovaries and stuff removed. And believe it or not, when they did that, they found the cancer. Okay? So the genomics are being used not just for research, but in those cases where there is a very high percentage probability of something happening, patients are actually being informed of that so they can participate in making decisions in what they want to do with their care going forward. And of course, Geisinger as a health plan has about 600,000 members as well. Serves 3 million residents throughout 45 counties in Pennsylvania and also Atlanta Care in southern New Jersey as part of the system. 30,000 employees, 12 hospitals, 2 research centers, and recently now the Geisinger Commonwealth School of Medicine. When you have trouble getting doctors and nurses, why not start your own school of medicine? And that's a very new venture. Just want to share a little bit about where home health and hospice fits into the picture. We fit into population health, okay, which means that we're in with the skilled nursing facilities, Geisinger Life, which is the PACE program, nurse-family partnership, home infusion, community health and wellness, and the Keystone ACO, which is Geisinger's ACO. They're all our partners, and so we do a lot of things together, okay? As an example, I've just put together a program where telehome care services are being utilized. The same program is being utilized by home health, being utilized by the ACO, being utilized by Geisinger Health Plan. So we may admit a patient and have telehome care in there for 60 days on the episode. If that patient is an ACO patient or a health plan patient, that unit may stay in there and they will pay for it instead of us, okay? We don't have to take it out of the home. We also avoid the situation where we've had in the past where we've had 2 different devices in the same home. Home health had a device in there and the Geisinger Health Plan had a device in there. Now it's a seamless, moves from one provider or one payer of that device to another. Currently, as I mentioned, multiple providers being shaped into one. Majority of our patients are managed care, okay? Our traditional Medicare is only about 40%, okay? We lose money. Anybody surprised? Medical assistance is managed care in Pennsylvania. I mentioned that 3 years ago I brought a nonprofit VNA into the Geisinger system. At that point, that VNA was about 60% Medicare. In the last 3 years, having joined the Geisinger system and with the continued increase of managed care in the area, that organization is down to 40% as well. I mentioned staffing shortages. One of the other things that I think is typical for integrated health system home care programs, we get a huge disproportionate share, of clinical and financial cases that are difficult, okay? When case management can't find anybody else that wants this patient, we get a phone call, okay? And we get asked, insisted, arms twisted to take that patient. There's that constant tension always in our situation about improving our own bottom line versus serving the system, okay? I can lose $25,000 on a patient. It's still a good decision if the system can save $100,000 by getting that patient out of the hospital, okay? However, you've got to really document what you're doing to benefit the hospital. And for us, you know, it's assisting the hospital with throughput, reducing admissions, readmissions, ED utilization, shifting patients from SNF to home, partnering with the ACO, the bundles, all of those programs that the hospitals are now involved in. And so one of the things that was most difficult for me transitioning from a freestanding provider to being part of an integrated health system was that idea that, you know, before I always had to protect my bottom line, okay? There were patients that I would refuse, like many of you do on occasion, because you knew you were going to lose your shirts, okay? Now, I very well will take that patient because I know it is good for the health system. However, there is that question that I think everybody has. You know, is it your goal to maximize home health results or to maximize the value to the system? Okay? I have asked that question repeatedly in the last 3 years, and guess what? I still don't have a good answer, because most executives will expect that you will do both. okay? I have executives who still believe that we ought to at least break even, okay, on a 40% traditional Medicare, okay? It can't happen, all right? It's not gonna happen, okay? So you've got to work within the system to budget for an actual loss, and you've got to be able to document the fact that you are adding value to the system. And so we're working on several models right now of how to document that value so that we can continue to do what is right for the system without being called on the carpet all the time as it relates to our budget. All right, so what are some of the important things? Big picture versus service line goals we talked about. You know, are we ready for value-based care? As a management team, that's a big question. We're involved with the ACO. We're involved with the Geisinger Health Plan. We're involved with bundles. We have other programs that reimbursement is affected by value. New technologies, guess what? Virtual visits. We need to figure out how to do that. We're working on that. We don't have it in place yet. But our telehome care program, being able to share that across the continuum is going to be beneficial. Being able to work closely with care management, how to figure out those difficult patients. You know, sometimes you've got to figure out transportation for patients to get them home. Sometimes you got to figure out a home for these patients. So we often work hand in hand with care management to try and remove those obstacles that keep those patients in the hospital, okay? Hospitals sometimes get stuck with patients for months because they can't figure out how to get them out. It's very expensive. So some of our challenges, you know, our leadership team consists of managers that just a few years ago were from 3 home health and 2 hospice programs that all competed with each other. So while we knew each other, it was primarily as competitors. We now are part of a single management team, and people have been handpicked for different things. We've got a quality director who is in charge of quality across all the providers, soon to be one provider. We have a home health director, a hospice director, a medical records director, those types of people that have the entire responsibility. Your needs have to be well-defined. You need to have common goals and mission. It's hard to get everybody on the same page. We meet almost weekly, and our meetings are called re-engineering meetings because one of the things we have found is that we've got 5 different ways of doing things from the past, and what we've told people is we don't care how any organization did it in the past. What is the best way to do it now? What is the best standard practice of how to do this? So how you answer the phone, how you market, all of those things are being re-engineered from 5 different perspectives into one appropriate standard of care. It takes a lot of time to build trust and those relationships. So you need to spend a lot of time together. You need to check your egos at the door. You know, it is very hard, even for me now, after 3 years, to not slip into my previous role because I was with that organization for over 30 years, okay? So you really need to be on the same page, talking system-wide, one organization. You need to speak up, share ideas, challenge and question everything. One of the things I told the rest of my leadership team, who were, most of them were new to me as part of a team, you know, I told them, I said, you know, I know that you have accepted me as a leader when you are willing to, in the middle of a meeting, say, I don't agree with you. I think we should look at this differently. If I hear silence from you and you're taking everything I say as the final say, we're not a team. So you really have to give people permission to challenge, to question, to say, look, this is maybe another way to do this. And that can be very difficult to do, and it can be very difficult for managers to do because we all have our ego. We all like to think we're right. Change management, one of the things that I have found most difficult about bringing 5 organizations together and significant change in those organizations, okay? Remember, we came onto one EMR from 4 different systems. We had 5 different pay scales, 5 different benefits plans, 5 different on-call systems. Very difficult. But one of the things that I have found is that you really have to manage the change and take care of the people, because what happens when you get a lot of stress in those situations? Who are the people that are most prone to bail? They are the people who really care about what's going on and don't like the stress, don't like that things are not going smoothly. The people who are there just to collect a paycheck will stay there to collect a paycheck. So one of the things that we have worked very hard at is to try and make sure that we have taken care of our people. Because if you don't, when times get tough, oftentimes it is those people, your best people, who have other opportunities, okay? From my prior organization, the 200 staff people there came into a health system. We negotiated that they brought their seniority along with them. So guess what? They came into a health system with hundreds of openings, with maybe 20 years of seniority for benefit purposes and stuff. They all of a sudden had a great opportunity of jobs that they didn't have before, okay? And we lost some of those people, and we celebrated the fact that for many of them, they got great opportunities in the system. But it really, you've got to take care of your people if you want to make things work. We use some outside resources as far as leadership development. We also did the Gallup's strength-based leadership training. If you've never done that, that's a lot of fun. I can tell you that we identified in our team that one of the areas where we were not particularly strong was in the area of vision and strategic planning. That's not a good weakness to have, okay? We had a lot of very hard, dependable, responsible people, but we did not have a lot of visionaries, okay? So we had to, in our planning process and in terms of bringing other people in to assist us and stuff, make sure that we brought in some of those people that had those visions. We tried to make sure that people had opportunities to get to things where new ideas were being talked about, and tried to develop that within our own staff. Don't settle for average, okay? One of the tenets of the Geisinger health system right now, Dr. David Feinberg is the chief executive officer there, and his major premise in healthcare is that if you take care of people and keep them satisfied, they will come and you'll figure out the reimbursement, okay? So my first meeting with Dr. Feinberg, we were in a board meeting, and I'm sitting up there very proudly sharing that we have a 96% patient satisfaction rating. And Dr. Feinberg looks across the table and he says, "What are you doing for the other 4%? And you know what? I was kind of taken back, all right? I was feeling pretty good about 96%, okay? But I've seen him do that. I mean, you expect it now, okay? His expectation is that we will be 5-star rated, home health, hospital, health plan. Those are the expectations. No negotiations, and we don't settle for being average or being good, okay? Does not matter how you did it before. We need to look for the best practice. Another thing that I think kind of relates to what I mentioned with the Gallup that's really been important to me throughout my career is to staff to your weakness. You know, there are things that I know I'm not really good at, okay? And so I've always made sure that I have had people around me who were good in those areas, okay? I'm not the most detailed person, okay? So I need somebody on my team who reads those contracts and is into all that detail, okay? So as you're putting together teams and as you're developing leaders, you don't want people that are all like you, okay? There doesn't need to be 10 of you in the room. You need people with different skills, different ways of looking at things and stuff. So that idea of staffing to your weakness, I think, is important. You need to communicate. One of the things that has been our experience has been you can never tell staff too much. Now, I understand that legally and everything, there's a process you need to go through, but we need our people to understand the big picture as much as possible. Why are we doing things, okay? Again, when I brought my organization into the health system, it was not something that was universally popular, but we made it very clear as to why we were doing it. We were unable to keep salary scales at a level that was fair for our staff. We were unable to recruit. We were unable to guarantee that our referral streams were going to stay in line because of all the mergers and acquisitions and stuff that were happening in central Pennsylvania. So we felt that while we were in a position of strength, it was best to negotiate our way where we wanted to be rather than wait to the point where, guess what, we're not strong, and then we're going to look for any partner that'll take us. So communicate, be transparent. So those are some things that were important to us. We want to take some time, Ann and I wanted to have some time to have you ask questions. We think that's probably the most important part of this. I'm going to actually bring the microphone down. And you can pass it around. You first.
Yeah, I don't think it's on.
Hello. There you go. Okay. For the organizations, the home care, I guess they were home care organizations that you combined with. Were they acquisitions?
They came in a couple different ways. Some of them were independent. Some of them were acquisitions that came with hospitals that were acquired, which was interesting because in my case, in my prior organization, my board and leadership chose to make that change. In one of the situations, the organization really didn't want to be part of the system, but their hospital was acquired. And so they went along with it.
Okay. I'm from Berwick, Pennsylvania, by the way.
Okay.
12 miles from you. Okay.
Hi, I'm Judy from Vermont, and we're right in the position now of considering joining our integrated health system. We would be the first VNA to come in. And so one of the things that you said was, and we might have another Vermont Home Health Agency come in under us also, so it would be two of us. But so one of the things you said was be sure, because you don't want to lose those good people, be sure you take care of your people. So could you just talk a little bit more about that? What do I do to take care of my people?
When we negotiated our way into the system, we had certain provisions written into the agreement, okay? There were no staff layoffs that were going to occur within a year. Everybody would come in at least the salary that they had. Their years of service came along with them. Those types of things were actually put into the agreement, okay? And I will tell you, Geisinger Health System did a fantastic job of honoring every part of that agreement. Now, some staff still chose to leave. Some staff don't want to be part of a big organization. Some staff left because they got in there and they saw other great opportunities. But staff were very clear that we had done everything we could to really put them in a good position. Now, I will tell you, having then become the associate vice president that's in charge of all this coming in, within 6 months' time, I'm saying, some of these things I negotiated for the prior organization are now a headache to me, to be quite honest.
Just be careful, you're right.
On the edge.
Can I add something to that?
Sure.
Because I went through something very similar. You have to protect yourself, and your board has to protect you, because if you're the CEO, you are the most vulnerable. So you have to do, like Steve did, make sure that's all in writing, and get a contract. You might not want one, but it might help you. Just feel safer.
Hi, I'm from Houston, Texas, and I work for Memorial Hermann Healthcare System, the largest hospital system in Houston. And I'm just very interested in hearing about how you are showing your hospital leaders your value with home health services, because we are in a same situation. Same kind of mix of payers. We have a struggle every year with our budget because we lose lots and lots of money, but we support the healthcare system. We get patients out of the hospital. We provide charity care, and all types of high-end treatment, wound care, Plurax drains, all that. Lots of free care. So I'm very interested in that.
There is no established tool out there. You can do all the Google searches you want, and you won't find them. I found an organization, a former VNA that had joined a health system, that had developed a tool that they were using with the health system before they joined. They were willing to share that. We also, Geisinger has been going through a huge strategic planning process with an outside firm, and that firm offered to help develop some type of tool. So we have two different tools that we are now calculating the results on. There's no baseline or benchmark, though, okay? So it's really not real valuable now, but I'm hoping that a year from now, I'll be able to say, okay, this is what it was in 2017, this is 2018, and this is 2019, so that we can develop our own benchmark and goals and everything. Now, having said that, if people want to send me an email, I will share what I can, because I think it is an area where we as a group, if we could do some work, could really help ourselves. Because, being part of a system, we are asked to do a lot of things that benefit somebody else financially, and we don't get the credit for it.
I'm just going to add in just a couple of things that we're looking at, because I hear what you're saying, and I used to work for an independent VNA. So two different things we're looking at is the telehealth system that we actually use and the 30-day readmission rate. So if you compare that to the actual benchmark and what would the financial impact be to the hospital on 30 days, that's a way of demonstrating your value. The other thing that we're taking a look at is we partner with our hospital for ED to home and promise either a same day or next day visit, and probably about 50% of those patients have behavioral problems, or they're homeless, or there are other things. So they tend to be LUPAs. So the organization in those cases does not get reimbursed. So we're looking at ways to track that so that we can also calculate how much we spend. And also for patients that are an eval only, we're also looking at how can we track them charity. There is still charity care still out there going on, people who don't have any payer. But yes, I hear what you're saying, and I think if we all could come together and figure out a way to really demonstrate our value in dollars, I think it would go a long way.
The other thing that I would mention is if you are part of an integrated health system, you very likely may have an ACO or a health plan there, okay? The ACO has huge amounts of Medicare data available to them, okay? So the ACO has the capability of going back and saying, okay, our average Medicare spend for patients is X, and our average Medicare spend for home health within those patients is X. But they also can break it down by home health agency. And one of the things we were able to do is to work with the ACO and the health plan to show that our costs were on the low side of home health and that our outcomes were better than the average for home health, okay? And a lot of it has to do with the types of payers. In our marketplace, there's quite a few proprietary payers. Some of them are very therapy focused. And so on some of those patients, ACO patients, bundle patients, it's very clear that some home health agencies are a lot more expensive than others. So work within the resources that you have in your system as well.
So they actually have, they've created this program for first-time leaders. So it's actually, I believe, a 3-day course. Part of that is a webinar, and it also includes follow-up with the individual. So it's like the skills that you need as you come into management. And often one of the most challenging areas, I think, for new managers is all the people stuff that goes on that managers underestimate how difficult that can be to manage. They're also creating a part 2 to that at this point that would probably be more advanced management skills, and it'll also have a 360 in it that will help to give feedback as far as how your peers and how your people who report to you and people above you, how do they view you as far as your leadership style, which can be really beneficial. It's developing. It's still in a development phase. There's a course on giving feedback, having difficult conversations. I think there also needs to be one on how do you do an evaluation for an employee. I think that's, one of the things that we don't do very, very well as leaders sometimes when we bring people into management. We don't explain to them, how really that process should work and that it shouldn't just be a one-time event and that it really should be continuous during the course of the year. Thanks, Judy.